Hi everyone, thank you for joining us for our first Matilda Centre webinar of the year. It's wonderful to have you all with us. My name is Christina and I'm a postdoctoral research fellow here at the Matilda Centre for Research in Mental Health and Substance Use, and I'll be chairing today's session. So I'd like to give a warm welcome to our speakers for today. So we've got Dr. Christina Marel and Ms. Erin Madden from the Matilda Centre here at the Uni of Sydney. And before I introduce them properly, I just have a couple of admin things I wanted to cover. So firstly, I'd like to let you know that today's session will be recorded. So both the recording and the slides will be available for you to download if you'd like to do so. And you may also notice that there's a question and answers section at the bottom of your dashboard there, a Q&A section. So what you can do is use this to type in any questions you have throughout the webinar, and we'll have a question and answer section at the end of the presentation. I also want to draw your attention to one of our upcoming webinars on the 14th of August, which will be presented by Associate Professor Kathy Mialopoulos and her team, which will focus on the cost effectiveness of prevention for mental health and substance use disorders. So for those of you who are joining us for the first time, I'd like to give you a quick overview of what the Matilda Centre is and also the type of research that we do. So the Matilda Centre was established in late 2018, so last year, and we were formerly known as CREMS, or the Centre of Research Excellence in Mental Health and Substance Use. And along with our name change, we recently relocated to the University of Sydney. So at the Matilda Centre, we focus on conducting research to improve our understanding of mental health and substance use disorders, and we also develop and trial innovative prevention, early intervention, treatment and translation programs for these disorders. So to achieve these aims, we work closely with services, schools and community groups, and this webinar series is another way that we can keep those lines of communication open. So this is a photo of our team at the Matilda Centre, and you can see our director, the lovely Professor Marie Thiessen, circled in yellow there at the back. Professor Thiessen is an NHMRC Principal Research Fellow, and she's also Director of the NHMRC Centre of Research Excellence in Prevention of Mental Illness and Substance Use, which is known as PREMIS. In 2018, just last year, she was appointed by the Minister for Health, Greg Hunt, as a National Mental Health Commissioner in recognition of her work, and she was also awarded a Companion of the Order Australia, which demonstrates her major contribution to Australia's health and medical research efforts in the field of mental health and substance use. So it's with great pleasure that I can introduce our speakers for today. So we've got Dr. Christina Marel and Ms. Erin Madden. So Christina is a Senior Research Fellow and Program Lead of Treatment and Translation among Complex Populations here at the Matilda Centre. And she's also primary author of the National Comorbidity Guidelines, the second edition, which she'll be discussing today. So her research is focused on improving our understanding of and also our responses to comorbid mental health and substance use disorders. And then we've got Erin, who is a research officer who's also based here at the Matilda Centre, and she's been working with Christina on the dissemination and online translation of the guidelines. So a big thank you to both of you for joining us today. We're very lucky to have you with us, and I'm sure it'll be a great presentation. So I'll hand over to you guys now.
Thanks very much, Katrina, and hi everyone who's tuning in. Thanks so much for joining us today. So as Katrina mentioned, Erin and I are going to be talking about building capacity in the alcohol and other drug workforce and the second edition of the National Comorbidity Guidelines, as well as our online training program. In terms of how we'll be doing this today, I'm going to be talking first, and I'll give a brief overview or an introduction to comorbidity, which will provide a little bit of a context for the rest of the talk. I'll then talk about a holistic healthcare approach, which really underpins our approach that we've taken to the comorbidity guidelines, followed by how to identify comorbidity, including where to access a range of evidence-based screening tools and assessments. I'll then talk a bit about the evidence in terms of managing and treating comorbidity. And I'll then be handing over to Erin Madden, who, as Katrina mentioned, is a research officer who works with us on the guidelines and our online training program. She'll be talking about the importance of involving multiple services to deliver a coordinated care approach. And we'll wrap up with a short demonstration of our Comorbidity Guidelines online training program. So this is a training program that's free for anybody to register and complete, and Erin will tell you more about that. If you're already familiar with what I'll be talking about in the first half of the talk today, please feel free to let your attention wander and come back to us in the second half. I'd also like to say that although the majority of the material from what we'll be covering in today's talk is drawing directly from the Comorbidity Guidelines, we're not actually going to be walking through them in detail, but highlighting sections in particular that we think will be of use to AOD workers. So we really encourage everybody out there, if you haven't already, to download a copy of the PDF of the guidelines from our Comorbidity Guidelines website, and we'll have a link to do that at the end of this talk. We'll also, you can also register for our online training program. If you don't have access to a hard copy of the guidelines, you can either get in touch with us and we can send one to you, or excitingly, you can now download one, order a copy from our guidelines website. So just by way of brief background, in 2007, the Australian Government Department of Health and Ageing funded researchers at the National Drug and Alcohol Research Centre to develop the first edition of the National Comorbidity Guidelines, or the guidelines on the management of co-occurring alcohol and other drug and mental health conditions in alcohol and other drug treatment settings under the Comorbidity Initiative. So since their publication in 2009, almost 16,000 hard and electronic copies have been distributed across Australia, and training was rolled out nationally, which was face-to-face, train-the-trainer approach to accompany the guidelines in 2010. And they also became a recommended text for students who are studying courses in alcohol and other drugs and mental health. So although these were an extremely successful and popular clinical resource, since they were first published in 2009, the research relating to the management and treatment of comorbidity has really grown considerably. We were funded by the Department of Health to update, revise and distribute the guidelines, and so they would reflect the most recent evidence. As many of you may know, and as Katrina talked about at the beginning of this webinar, in December last year, the Centre of Research Excellence in Mental Health and Substance Use, or CREMS as we were known, moved from the National Drug and Alcohol Research Centre at the University of New South Wales to the University of Sydney, and we started a new and very exciting research centre called the Matilda Centre for Research in Mental Health and Substance Use, and the Comorbidity Guidelines is one of the resources that moved with us. So the development of the second edition of the guidelines was based on a synthesis of the best available evidence. And this was identified by comprehensive literature reviews, feedback from a multidisciplinary panel of experts made up of consumers, carers, academics and clinicians, and feedback from other interested stakeholders at an open discussion forum. The expert panel and discussion forum also gave us feedback on preferred mediums of dissemination and translation. So the second edition of the guidelines were officially launched in 2016, and they aim to increase the knowledge and awareness of comorbid mental health conditions in alcohol and other drug treatment settings, improve the confidence and skills of alcohol and other drug workers, and increase the uptake of evidence-based care. So now you've heard a little bit about how the guidelines came about, so I'll get started with what we know about comorbidity. And before doing that, I just wanted to clarify by what I mean when we talk about comorbidity. So broadly defined, comorbidity refers to the co-occurrence, either lifetime or current, of two or more disorders. And our focus here today is really on the co-occurrence of alcohol or other drugs, or AOD, and mental health disorders or conditions. There are, of course, lots of other types of comorbidity, including other AOD use disorders, including tobacco, physical health conditions such as cirrhosis, hepatitis, heart disease and diabetes, intellectual and learning disabilities, cognitive impairment, and chronic pain. And the co-occurrence of one or more AOD use disorders with one or more mental health conditions is often referred to as dual diagnosis. This term can sometimes be misleading because many clients present with a range of co-occurring conditions of varying severity. We also know that comorbidity is common. So mental and substance use disorders are two of Australia's most common and burdensome health conditions. They affect around 1 in 5 Australian adults each year, and they frequently co-occur. It's estimated that about 1 in 3 Australians with a substance use disorder also have a mental health disorder. This can be as high as 75% among people who are seeking treatment. In terms of the most common mental health conditions that we see to co-occur with substance use disorders, these are typically the same as those that we see in the general population, which are anxiety and depression, PTSD and personality disorders. We also see elevated rates of bipolar disorder, psychosis, ADHD, OCD, and eating disorders. And the fact that these disorders co-occur is problematic because once they're established, each serves to maintain and exacerbate the other. There are also a lot of people who experience symptoms of their disorders but don't necessarily meet the full diagnostic criteria for a diagnosis of a disorder. And so this means a lot of people can have their lives significantly disrupted by mental health symptoms without necessarily meeting the diagnostic criteria. They can sometimes fly under the radar of a lot of services. Not only do people with comorbidity experience symptoms of their mental health and substance use disorders, but they also have quite complex presentations which can complicate their treatment and recovery. And research has shown that people with mental and substance use disorders die an astonishing 20 to 30 years earlier than the general population, and they spend the last 10 years of life living with disabling chronic illnesses. But comorbidity is not an insurmountable to treating people with AOD use disorders. Research has shown that people with comorbid mental disorders can benefit just as much as those without in turn from usual AOD treatment. So in terms of the holistic healthcare approach, which, as I said, really underpins the approach that we've taken to these guidelines, we know that people with comorbidity are at particular risk of developing cardiovascular disease due to high rates of smoking, overweight and obesity, diabetes, poor diet, physical inactivity, high rates of alcohol consumption, and the use of some antipsychotic medications. So research has really highlighted the need for interventions that focus on overall well-being, including reducing smoking, improving dietary habits, increasing physical activity, and improving sleep patterns. So from an AOD worker's perspective, remembering that physical and mental health are entwined, fundamentally entwined, and focusing on overall well-being by providing a holistic response and taking steps to manage both clients' physical and mental health is likely to lead to improved outcomes. But some service providers are sometimes reluctant to address multiple health behaviours because of the belief that making too many lifestyle changes might undermine a person's recovery from their AOD use. And although this is particularly evident in relation to smoking cessation, it's not really supported by the evidence, which really supports the use of multiple health behavioural changes. So some strategies that can really help AOD workers overcome some of the barriers which are associated with behavioural changes include helping clients minimise the physiological symptoms of nicotine withdrawal with nicotine replacement therapy or NRT, and of course being mindful of the different doses and the potential for NRT to interact with the metabolism of different medications, and of course the contraindications for the NRT. Using the Australian dietary guidelines to help clients develop healthy eating patterns or the food spending structure, and this is a tool that links household budgets to different food groups. The food and activity diary and devices that track physical activity, such as pedometers, heart rate monitors, and fitness trackers as motivational tools, as well as healthy sleep habits. So the broad focus of a holistic approach is really centred on delivering the right services to the right person at the right time. And this means that AOD workers' roles really include involving multiple services in a coordinated, client-centred approach. And this also means that healthcare workers should be prepared to not only address mental and physical well-being, but also involve and partner with other services that can provide complete individualised care. So moving on to how comorbidity can be identified. Despite high rates of mental health conditions among clients of AOD services, the detection and treatment of these coexisting problems usually or tends to be quite low. And that's why it's really important that all clients are screened systematically and assessed for such problems. Awareness of co-occurring problems will assist with the management of more complex presentations and treatment planning. But of course, to identify problems accurately, there might be a need to involve professionals who are trained and experienced in differential diagnosis. And screening can help identify the potential need for more formal psychiatric assessments. And multiple assessments conducted throughout treatment can take into account changes in symptoms over time and then be fed back into the treatment process. Clinicians and healthcare workers are also encouraged to become familiar with the DSM-5, and in particular its uses, its limitations and recommendations regarding differential diagnosis, or which symptoms are attributable to different disorders. It can also be quite useful to be aware of different signs of disorders, so what is objectively visible about a client, for example, sweating, as well as symptoms of disorders or what a client describes, such as sadness. So 3 elements that can be quite useful and helpful in identifying comorbidity that I'll briefly touch on include screening, assessment, and case formulation. So screening is a process of identifying possible cases of co-occurring mental health conditions. It's not a diagnostic process, so it can't establish whether a disorder exists, but it can be quite useful in identifying symptoms which are typical of a disorder and really highlights the need for further assessment. Ideally, screening should be conducted after a 2 to 4 week stabilisation period, but of course in practice, that's not necessarily practicable, particularly in treatment settings. So workers really need to be aware of the potential for false positives, which can occur if clients are screened during periods of acute intoxication or withdrawal. And to avoid the possibility of misdiagnosis or false positives, multiple assessments should be conducted over time. Some instruments that workers might find useful include the Camberwell Assessment of Need Short Appraisal Schedule, or the Kansas, the Kessler Psychological Distress Scale, or the K10, and the Depression Anxiety Stress Scale, or the DASS. So the Kansas P, the K10 and the DASS-21 and their scorers, as well as some additional screening tools which cover a broader range of conditions, can be accessed in the Comorbidity Guidelines. Another resource which might be useful is Mark Deedy's 2009 review of screening and assessment tools for use in AOD settings. This is quite old now, it's 10 years old, but it's really useful because, I think it's really quite useful because it includes a comprehensive overview of all screening and assessment measures, where they can be accessed, whether there's a cost involved in their use, details of their reliability and validity in AOD settings, as well as their strengths and their limitations. And it's free to download from the NADA website, and the hyperlink is there on that slide, which you should be able to click on in the handouts that will be available at the end of the talk. So assessment involves a detailed investigation of a person's mental health, and this should be an ongoing process that takes into account changes in mental health symptoms throughout treatment. It informs case formulation and treatment planning. The depth of assessment really depends on the needs of the person at the time. So for example, the amount of information that's needed for a brief intervention is of course much less than what would be needed for extensive treatment. But the components include presenting issues, AOD use history, medical history, risk assessment, psychiatric history, trauma history, mental state, readiness to change, family history, criminal history, current situation, strengths and weaknesses, personal history, and the source of referral. And I won't go into detail about these, but just to say that more information about them can be found in the guidelines. The process of case formulation then involves gathering all of the information regarding the factors which might be relevant to treatment planning and formulating a hypothesis of how they all fit together to form the current presentation of a client's symptoms. And then after developing that case formulation, workers should be aware of what problems exist, how they developed, how they're maintained, as well as all the aspects of the client's presentation, so their current situation and the interaction between the different factors and problems. And this is really the first step to devising and then later revising the client's treatment plan. So the primary goal of any service should really be about improving clients' and patients' quality of life. But of course, in order to do that effectively, workers really would be thinking about taking into account the broad range of issues that people present with. So in addition to all of those factors that I mentioned before, consideration should also be given to the client's age, their sex, sexual orientation, their ethnicity, spirituality, socioeconomic status, and their cognitive abilities. It's also important to differentiate between substance-induced and independent mental health disorders. So symptoms of mood, anxiety, and psychotic disorders can all be induced as a result of AOD use or withdrawal. So for example, alcohol use and withdrawal can induce symptoms of depression or anxiety. Manic symptoms can be induced by intoxication with stimulants, steroids, or hallucinogens. And psychotic symptoms can be induced by withdrawal from alcohol or intoxication with amphetamines, cocaine, cannabis, or LSD. So to find out whether a disorder is substance use or independent, we can ask whether the client has any current mental health symptoms like depression, anxiety, or psychosis, whether they've experienced them in the past, and whether they have ever been diagnosed with a mental health disorder. If they have experienced mental health problems or been diagnosed with a mental health disorder, we can ask about the timing of those symptoms. So when did they start? Was it prior to the AOD use? Do they only occur when the person is intoxicated or withdrawing? Have the symptoms continued even after a period of abstinence of about a month? Did the symptoms change when the client stops using substances? Did they get better, or did they get worse, or did they stay the same? And is there a family history of that particular mental health condition? If the symptoms only occur in the context of intoxication or withdrawal, it's likely that they're substance-induced and will resolve after a period of abstinence without the need for any direct intervention. But having said that, it's still really important to manage the symptoms to prevent the client from relapsing. If the symptoms started before the onset of substance use, if they persist even during periods of abstinence, or if there's a family history of that particular mental health condition, the client might have an independent mental health condition. It can also be quite difficult to distinguish substance-induced psychosis from other psychotic disorders. And if a person is experiencing symptoms of psychosis, it might not be possible to elicit information that can help assess the onset of symptoms, their family history, their AOD use, and so on. But some substance-induced symptoms can help differentiate between substance-induced psychosis and independent psychotic disorders. The substance-induced symptoms tend to appear more quickly, they tend to last a shorter time until the effects of the drug wear off, although for some people they can last longer. And visual hallucinations tend to be more common in substance withdrawal and intoxication than in primary psychotic disorders. Some of the common symptoms of low-level crystal methamphetamine-related psychosis include suspiciousness, guardedness, and hypervigilance, such as constantly being on the lookout for threats, overvalued ideas, which might be ordinary events which have special meaning or significance, illusions or misreading the environment, such as a shadow looking like a person walking into a room, or a random sound sounding like a police siren, erratic behaviour, which might seem like paranoid ideas, such as accusing other people of having wronged a person or arguing with bystanders for no apparent reason. Stimulant psychosis is more commonly associated with tactile hallucinations, which is sometimes referred to as icebugs, and people experiencing stimulant psychosis may be more agitated, energetic, and physically strong, and also can be challenging to control in a safe environment. And they may also be difficult to calm with sedating or psychiatric medication than independent psychosis. So to give a quick summary of what I've covered so far before I move on, we know that comorbidity is common and it can complicate a person's treatment and recovery. Once comorbid conditions have been established, it's most likely that the relationship between them is one of mutual influence. Given the high rates of co-occurring mental health conditions among clients of AOD services, it's essential that routine screening and assessment is undertaken for conditions as part of case formulation. Consider a range of factors in the process of case formulation, so not only a person's AOD and their mental health issues, but also socio-cultural factors, their motivation, their living situation, and of course the medical and personal history. Full assessment should ideally take place after a period of abstinence, or at least when the person is not withdrawing or intoxicated, and conduct multiple assessments throughout treatment because symptoms can change over time. And I've just added an additional point here, the importance of providing assessment feedback to the client in a positive and easily understood way. So in terms of the evidence of managing and treating comorbidity, before I talk about this, I just wanted to quickly touch on models of care. So in terms of approaches to comorbidity, there are 4 main models in the treatment of comorbidity, and these are sequential treatment, parallel treatment, integrated treatment, and stepped care. I won't really go into detail about them, but I just wanted to point out there's been a lot of discussion about models of care for people with comorbid conditions, but there's, I guess, little research available to determine which models might be better suited to which comorbidities. So it's likely that AOD workers may need to make pragmatic decisions about which model is best suited for their individual clients. But having said that, the idea of integrated treatment for 2 disorders has considerable intuitive appeal and has a lot of advantages over other treatment approaches, including a single point of contact, so the client doesn't fall through the gaps, There are common objectives, the treatment is internally consistent, the relationship between the AOD use and the mental health conditions can be explored, and communication problems between agencies does not interfere with treatment. So as I said, although the research is quite limited in this space, there is some emerging evidence to suggest that integrated treatment may be superior to parallel or sequential treatment in terms of improving outcomes. So we make a distinction between the management and treatment of comorbidity, in that the goal of management of mental health conditions is really to allow AOD treatment to continue with minimal disruption or dropout. So management strategies, which are described in the guidelines, provide short-term relief and control over symptoms, which is an interim measure during AOD treatment until full treatment of co-occurring conditions is possible. So the guidelines provide do's and don'ts and practical strategies for managing co-occurring or commonly co-occurring conditions. There are a range of options for managing and treating comorbidity, and of course, not all treatments will suit everybody. Although workers are likely to be familiar with the more traditional psychological and pharmacological approaches, these have limited evidence for comorbidity. And in the absence of more specific research, it's generally recommended to use the most effective treatment for single disorders. Both psychological and pharmacological interventions have been found to have some benefit, and when pharmacotherapy is used, it should be accompanied by supportive psychological interventions with workers aware of the potential interactions between medicines and also other substances. In addition to these approaches, a new edition of the guidelines, that we've included is a discussion of e-health interventions, physical activity, and complementary and alternative therapies. So for a lot of disorders, exercise and physical health interventions have been shown to have some benefit. For example, with ADHD, schizophrenia, bipolar, depression, anxiety, OCD and PTSD, as well as eating disorders, although a lot more research is needed on comorbid disorders. So I won't go into detail here, but we have discussed the evidence regarding the treatment of disorders for ADHD, psychosis, bipolar, depression, anxiety, OCD, PTSD, eating disorders and personality disorders. And in addition, management of symptoms that might cross various disorders such as anger, grief and loss are provided. So I'll now hand over to Erin, and she'll be talking through a coordinated care approach and also give a demonstration of our online training program. Thank you, Erin.
Great, thanks Chris. So I'm going to talk to you guys now briefly about why coordinated care is essential to delivering the treatment options for comorbidity that have been discussed so far. So one of the biggest risks in referring clients to external services is the potential for clients to fall through the gaps and disappear from treatment altogether. And many of you are likely familiar with this image here, which represents how clinical services have traditionally adopted more of a siloed approach in which mental and substance use disorders are treated separately, which limits treatment effectiveness. And as a result of this, people can be bounced between mental health and AOD services with little continuity or coordination of care, and they fall between the cracks in our health system. So just to give an example of what this might look like in practice. So one possible scenario might be someone starting with a referral from their GP for an AOD counsellor, but when they get there, the counsellor refers them to a psychologist instead. So they re-enter the roundabout, only to be told by the psychologist that a psychiatrist is actually needed. However, when they try the psychiatrist, their calls aren't returned or it's full, and they face a closed door. So this is just one example of what can happen in practice, and there are a lot of services that people need to navigate their way through in reality. So people with comorbidity often have difficulty navigating their way through available services, which, as we can see here, can be incredibly difficult to access with multiple entry points and multiple options of, treatment pathways, agencies, and healthcare providers. So often by the time someone with these disorders is ready to access treatment, they've been experiencing symptoms for many years, and it can then be incredibly challenging to be bounced around and referred between providers. So therefore, it's really critical for care coordination and with the referral process to focus on linking clients with services as smoothly as possible. So the development of the formal links between services regarding consultation, referral pathways, and collaboration can really help with this process. So coordinated care increases the likelihood that clients will receive specialised assistance where it's needed and facilitates client engagement in treatment. and evidence has linked coordinated care with improved treatment outcomes, such as prolonged client retention, increased treatment satisfaction, improved quality of life, and an increase in the use of community-based services. And in terms of the AOD worker's role in coordinated care, so although coordinated care is facilitated by an identified coordinator or case manager, they're not expected to provide all the necessary services themselves, but instead refer to and manage the engagement of these appropriate services. And the challenge is in that active engagement of multiple services and service providers with a mixture of professional and non-professional support. So AOD workers are in a primary position to coordinate care and incorporate the many services that reflect the particular needs of clients to deliver the best possible quality care that they can. So I'll now walk you through our Comorbidity Guidelines free online training program, which is a fantastic place to learn how to put all the things that we've been discussing today into practice. And just before we go on a tour, I'll give you a little bit of background info about the online training program itself. So our training program is based on the guidelines, which were developed by researchers at the Matilda Centre in consultation with clinicians, researchers, consumers, and carers. It's completely free and it takes about 10 hours to complete online. So ultimately, the online training program aims to increase the uptake of the guidelines and facilitate their translation into practice. And it does this through 4 key aims. So the first being to increase the knowledge and awareness of co-occurring mental health conditions among the AOD workforce. Secondly, to improve the confidence and skills of AOD workers to manage these co-occurring conditions. Thirdly, to increase the uptake of evidence-based care. And lastly, of course, to improve the outcomes for people with co-occurring AOD and mental health conditions. And as Chris mentioned before, for the first edition, we had a national Train the Trainer, which is a face-to-face training program. But this time we've decided to initially translate the guidelines into an online program instead. And we've done this because online training has the capacity to overcome many barriers of traditional training models, which makes it a far more sustainable method of providing training. So online training ensures the program is consistent, convenient, more feasible, with wider reach, and it can be remain up to date easier than traditional training methods. And as users have control over their own training programs, it also reduces information overload, and it also has a shorter delivery cycle time, meaning that the gap between learning the content and actually putting it into practice is lessened. And the training program was developed in line with e-learning principles, which is to say that it is interactive with a clear rationale for the overall course, as well as clear objectives for each individual module. And e-learning is also most effective when there is strong job-relevant content based on the most up-to-date evidence available. So the program is based on a multimedia approach, as we know that information is remembered better when it's presented in different modes, such as animations, narrations, videos, and case studies. And we wanted to avoid a Las Vegas approach, where there is too much stimuli causing a bit of a cognitive overload. And you've probably seen a lot of websites that look like this. So we want to make sure that the graphics support text, and if they don't serve a purpose, they are distracting. So for example, the photo on this slide has actually nothing to do with what I'm talking about, but it probably grabbed your attention for a second or two and even distracted you from what I was talking about while you tried to figure out what it was actually doing there. And we want to make sure that all the information in the program is relevant to the training program itself. And finally, research indicates that an important aspect of e-learning is assessment. So for a person to retain information, they must be able to retrieve it. So here's what our homepage of the website looks like, with the URL up the top there for anyone wanting to access the website. And from here, you can access the online version of the guidelines. You can read more about the training program or register for training. Or access additional resources and links such as client worksheets, screening tools, or assessments that Chris was talking about before, and links to external resources. So the 2 most accessed links are at the top here. So this includes a link to order a hard copy of the guidelines, which, as Chris mentioned, completely free to all Australian addresses, and we send them on a monthly basis. And of course, the link to register for online training. So this is a really quick process. It's just a form with only 5 fields. And then once you fill that out, you'll immediately receive an activation code via email. And once this is verified, you'll be taken straight to our training page. So this is what the training homepage looks like. This page is where all of the training modules can be accessed, and they will change color once they've been completed. So as you can see, the person here has completed the introductory module. So there are 11 modules, and they can be completed in any order, which will unlock after this introductory module has been completed. So for example, if you only wanted to do a module on treatment options, you're free to only complete module 8, or if you want to upskill in identifying comorbidity and assessing risks, you could only do modules 5 and 6 if you like. And your progress through the modules is tracked up here. And if you'd like to go through key learning outcomes of a module before you start completing it, or your workplace asks you, what does this training actually cover, you can refer to the key learnings document there. So I'll now walk you through one of our modules, and this person has completed the introductory module, which is then unlock the other modules. And we're going to explore module 1, which is what is comorbidity. So each module starts with a clear overview of what will be covered and the time the module will take to get through. All the modules vary in length, but if you were to run through the whole program back to back, it would take about 10 hours. And the training is fully accessible, meaning the whole program is narrated. It's also very user-friendly and easy to navigate through the sidebar there. You can go back and forth between content as you need. And once you've viewed a slide, the corresponding bullet point will turn yellow, as you can see here. So your progress is also tracked in the top right-hand corner over here. And as you move through the module, this will show you how much of the module has been completed. And lastly, just wanted to draw attention to the fact that each module has been based on specific chapters of the guidelines, which have been hyperlinked if you want further information or more detailed information. So each module has clearly defined key learning outcomes, which are assessed in each quiz at the end of the module. And we've used different multimedia approaches and have incorporated case studies throughout the training as well. And as I mentioned before, this is a good example of text being supported by relevant graphics that help to visualize information. So in collaboration with clinicians, consumers, academics, and AOD workers, we also developed a series of short animations through Twisted Media in line with our multimedia approach. So this one will give you a brief overview of comorbidity, and in other modules you'll find animations explaining some of the more common disorders that co-occur with substance use, such as depression, anxiety, and psychosis. And we've actually made these available to the general public on our Vimeo site as well, if you want to take a look there. So in addition to animations, we also use video examples of treatment methods in other modules. So this one will give you an example of cognitive behavioral therapy, and another one will give you an example of motivational interviewing. And we've had feedback from those undertaking the program that this is really helpful to see what these options actually do look like in a clinical setting. And this module covers a similar introduction to comorbidity that we've provided in this webinar, but just in a bit more depth. And each training module will end with a summary of the key learnings before moving on to the quiz. So I've zoomed out a little here so you can see the full quiz. Each module after the introduction features a 10-question quiz designed to test those key learnings. And these include a variety of question types, including multiple choice questions, tick all that apply questions, and fill in the blank questions, just to name a few. And so we've covered the answers here to not give anything away, but wrong answers will feature a link to the corresponding section of the guidelines for more information. And you can redo the quiz as many times as you like. So there are no maximum attempts. And once all questions are answered correctly and all the slides have been viewed, the module will be complete. And once all modules are complete, as you can see here, a link to download your certificate will appear over here. And this will list the number of hours, which depending on your registration provider, you can claim for CPD. So just to give a summary, AOD and other mental health disorders are very common. Clients with comorbid mental health conditions often have a variety of other medical, family, and social problems. So this could include housing, employment, welfare, and legal problems. And as such, it's really important to adopt a holistic approach to the management and treatment of comorbidity, which is based on treating the whole person and not just the illness. And it's important that comorbidity is identified so that it can be managed and treated appropriately. And in addition to mental health services, AOD workers may need to engage with a variety of other services to meet clients' needs. And these might include things like housing, employment, education, training, community, justice, and other support services. So before we finish, I just want to let everyone know that we're in the process of developing a more in-depth face-to-face training program based on the guidelines content. I described the many benefits of online training earlier, but online training won't necessarily suit everyone or every service. And we're hoping to have this completed by the end of the year. If you'd like to be notified about when it's completed or find out more information, you can email us at inquiries@comorbidityguidelines.org.au. So that concludes our overview of the online training program and our webinar. Thanks once again so much for joining us. And once again, our website is comorbidityguidelines.org.au, and you can order a free hard copy, download a PDF copy, or register for our free online training program. And if you'd like further information about the guidelines or want to discuss ideas for implementing them or our resources as training within your workplace, please email us. So you can email me at erin.madden@sydney.edu.au and CC Chris at christina.marel@sydney.edu.au. So I'll hand over to Kat now to take questions for us. Thanks, Kat.
Awesome. Thank you both so much for walking through that awesome resource that you've got there. And it's great to hear about the online training option. We've had a couple of people already saying they're ordering copies of the guidelines, which is fantastic. And I look forward to hearing more about the face-to-face training over the coming months. So we have about 10 to 15 minutes for questions now. So if people are interested in posing a question to Christina or Erin, feel free to type it into the Q&A section at the bottom of your dashboard. But in the meantime, we had a couple of questions come through via email before the webinar, so I might kick off with one of those. So the first one that I'm curious to hear myself is whether we're likely to see a national comorbidity guidelines that target needs of mental health workers rather than AOD workers specifically.
Hello. I'd love to do mental health guidelines for use in mental health settings or corresponding guidelines. This has been something that's been on my radar for a while that I've really been keen to do. Unfortunately, we haven't been successful in obtaining funding to do those, but it is definitely something that we would be keen to pursue. Meanwhile, if anybody has any funding available or has any ideas for where we could find funding to do those, please get in touch and let us know. But in the meantime, we will keep pursuing that because it is something that we would like to do that, yeah.
Awesome. Thanks, Chris. And another question that's just come through is whether the guidelines discuss the role of families or carers in treating comorbidity.
I think that, yes, so the role of carers and families is really important. And of course, including families and carers is really essential in terms of providing different perspective and to what a client or a patient might be telling you in terms of filling in the gaps. But of course, it's important to get clients' consent before involving any families and carers. I'm not sure whether we do include that in the guidelines specifically, but it's definitely something that we should if we don't. And if we will be revising these at some point, I hope. So if we don't explicitly say so, then we will include that in the next one. Yeah, very good question.
Yeah, good answer. And another one for you, Christina, again. So you mentioned that some professional knowledge is needed to accurately identify comorbidity, but is there any specific training that people can do to actually increase their knowledge?
Yes. So the good thing about the management strategies that we described is that you don't actually need any specialist training to be able to implement them. They're described in detail in the guidelines and the training, and there's actually a lot of links that we didn't include in this, but you can find them in the guidelines and also in the training program. For the treatment of comorbidity, more specialised knowledge is often needed in terms of specific treatment approaches. Erin had a few slides up there that talked about CBT and motivational interviewing. But if anybody's interested in finding out more about that, you can seek out more training opportunities through your own professional development associations.
Awesome. Thanks, Chris. Sorry, I'll just have a look through here. Someone's asked whether you think it could be relevant for other community service workers too, and they've mentioned that they think it's a fantastic resource.
Oh, thank you. Yes, absolutely. Definitely. So we were funded to develop them for alcohol and other drug workers specifically, but we have feedback that they are being used more broadly than that. So as I mentioned earlier, by students studying courses in alcohol and other drug and mental health, but also in social settings, social service settings, and more broadly in healthcare care settings more broadly. So definitely think that it can be used by anybody really. It's just got a little bit of assumed knowledge about alcohol and other drugs, which is not covered in detail, but there's no reason why it can't be used more broadly.
Excellent, fantastic. And another question is whether people need to be abstinent from alcohol and other drug use before treatment can actually commence.
Ideally, yes. In practice, particularly in alcohol and other drug settings, it can be, and a lot of other settings, it can be really difficult for people to maintain abstinence when they're experiencing mental health symptoms, particularly if they're using substances to relieve or help them cope with their mental health symptoms, as you would know. That's why treating both the substance use and mental health disorder at the same time in an integrated approach can be really important. So treating one disorder doesn't necessarily lead to worsening the symptoms of the other. So though people might not get the maximum benefit from therapy, if they're still using, they can still benefit. It's really important to work within their current stage of change whenever they're ready.
Beautiful, thank you. And how helpful would you say a diagnostic label is? What's your opinion on that?
I think for the client, it could go either way. So some people might find the label of a diagnosis quite unhelpful. They might think of it as a barrier to progressing through treatment. Others might feel a lot of relief in that their symptoms are normalised and validated. It'd be really up to the healthcare worker or AOD worker to judge how their client is likely to react, of course, within the boundaries of your therapeutic relationship. But for a clinician or a healthcare worker, a diagnostic label can be, of course, really important in terms of knowing what other services to liaise with in communication between other services.
Excellent. Well, thank you both for what was an excellent presentation, hopefully really informative for people who have joined us today. Just as a reminder for people listening, the webinar recording will be available along with the slides, and they'll be sent to anyone who has registered today, whether or not they could attend live now. And you can also email Christina or Erin directly if you'd like a copy of the slides as well. And so apologies to anyone who didn't have their question answered. There were quite a few coming in through, so I might try and forward any on to you, Christina and Erin, to have a look at and potentially answer.
And if anyone has any questions that you want to email us directly, yeah, feel free.
Yeah, exactly. Perfect. So we will be, as I mentioned earlier, we will be holding more webinars throughout the year. So the next one is on the 14th of August. So I encourage people to join us again for that, or if not, sign up to our mailing list so you can hear more about upcoming webinars as well. So thank you very much, and again, feel free to contact Christina or Erin directly. But yeah, I hope everyone has a good day. Thanks for joining. Bye.
Thank you.
Thank you.